So now we'll start talking about the actual different insulin formulations. So we'll start with talking about just reviewing the normal physiological secretion, and then remember that it can be divided into your relatively constant background level of insulin, your basal needs during the fasting and post-absorptive period, and then your prandial needs, which would be covered by your mealtime insulin. So remember that insulin sensitivity and secretion are not going to be constant throughout the day. So it is difficult to completely mimic your physiological requirements, but trying to emulate normal secretion of insulin is very useful to the treatment approach. And then using insulins that closely match the onset and duration of effect, which match your meal patterns and exercise schedules to achieve near normal blood glucose values throughout the day is a goal. So obviously for patients with type 1 diabetes who don't have any residual insulin secretion, 1 or 2 injections daily of any one formulation is not going to be sufficient. So they're going to need usually a minimum of 2 to 4 injections, depending on what type of insulins you use. You could use some combination products, so you could, but you basically do need basal and bolus coverage. So let's shift our focus to talking about those insulins that provide your background level of insulin constant secretion, and this can be achieved with the use of an intermediate acting insulin. So up until the advent of glargine about 25 years ago, NPH was really the agent that we utilized to provide your background basal insulin coverage. With an onset of 2 to 4 hours, it peaks within 4 to 8 hours and has a long duration of action of 8 to 12 hours. So it is given typically twice daily. The issue with NPH, as opposed to Lantus or Detamir, which are the newer, longer-acting basal insulins, which are peakless, is the fact that NPH does come with a peak at about 4 to 8 hours after injection. With this has its pros and cons. So if it's given first thing in the morning and prior to dinner time, you'll notice that that peak typically occurs right around lunchtime, so then oftentimes that patient does not need lunchtime prandial coverage. However, if they take it at dinner time, that peak also predisposes patients to overnight hypoglycemia around 10 p.m. to midnight. So NPH is a protamine. Its formulation is protamine is added to the regular insulin that forms a crystalline suspension and increases the duration. It's very important that patients roll, not shake the suspension, about 20 times in order to mix it properly, and it's the only cloudy insulin currently available in the U.S. So all other insulins are clear, NPH is cloudy. So the use again is as a basal insulin, but that peak also really provides bolus coverage at lunchtime. But because of that peak at lunchtime as well as overnight, there is higher rates of hypoglycemia. The benefit of NPH is it's relatively inexpensive, and it's actually available over the counter without a prescription for patients. So when they don't have coverage for glargine or Detamir, which can be very cost prohibitive, NPH can be an alternative approach utilized to provide that patient their basal needs. On top of this is NPH can be mixed in the same syringe with the bolus insulin. So if the patient is taking this prior to breakfast and prior to dinner time, they can also mix their bolus insulin prior to breakfast and prior to dinner time, and then reduce the frequency of injections to only twice a day. And what I've done here is try to give you a diagraphic idea of what the pharmacokinetics of these insulins look like. So you can see that your duration of NPH is typically going to be about 8 to 12 hours, so it's given twice a day, but you're going to have that peak around 4 to 6 hours after injection. So while the rest of the day it's going to be relatively constant, that peak is what's going to predispose patients to hypoglycemia. So at lunchtime, you want to make sure that they're taking their lunch as indicated and that they're not skipping meals. And then oftentimes for patients that are given NPH, we will tell them to take a high protein with a little bit of sugar as a bedtime snack to prevent them from dropping further low. There are a variety of long-acting insulins currently available, with the most commonly known one being Glargine that comes as the brand name Lantus and most recently Basaglar. And there is a concentrated Glargine that is available on the market that's known as Toujeo. And the benefits behind giving a concentrated insulin formulation such as a U300 that has 300 units per ml is that it's going to reduce the volume of insulin that's delivered and therefore enhance the absorption. So insulin glargine is going to be the most commonly prescribed and dispensed basal insulin. In the vial, it actually has a pH of about 4, so it's very, very acidic and it's very, very soluble, and it's a clear basal insulin. So when it's injected into the body, it forms microprecipitates that really slowly dissolve into dimers and monomers, which are then absorbed. And the result is then a long-acting insulin product with a duration of action of approximately 24 hours due to depot formation in the subcutaneous tissue. So again, 24 hours in the majority of patients. And specifically in type 1 patients. Keep in mind, though, for type 2 patients who are extremely, extremely insulin resistant, the duration of action is shortened, which oftentimes leads to individuals with type 2 diabetes needing glargine being injected twice daily. So the onset of action is 4 to 5 hours. There is no peak, and the duration in a type 1 patient is going to be estimated to be about 24 hours. And it's that substitution and that addition of those amino acid changes that result in those solubility changes that result in that subcutaneous depot forming at that physiological pH. Because it's highly acidic, you do not want to mix with any other insulin or solution because then that'll render it inactive. And its uses as a basal insulin. It's going to mimic the physiological insulin secretion much better than NPH is. The limiting factor with glargine is that it's very expensive. Insulin detamere, which is the brand name Levemir, is oftentimes used as another type of basal insulin with a little bit shorter duration of action when compared to glargine. So many patients will actually need to be taking it twice a day. It has an onset of 2 hours, and like glargine, it doesn't have a peak. So therefore, it really doesn't predispose patients to that hypoglycemia that you see with NPH. That prolonged duration of action is really due to a fatty acid side chain that binds to interstitial albumin, and then it's slowly released from that albumin at the injection site and then enters the blood. And when it enters the blood, it then binds to albumin again, even further prolonging the duration of action to 14 to 24 hours. The difference between glargine and detamere, it has a dose-dependent duration of action. So at low doses, 0.2 units per kilogram, it has a shorter duration of action, whereas at higher doses, that duration of action is extended. It does have less intra-patient variability compared with glargine and NPH, and there is less hypoglycemia, again, as similar to glargine when compared to NPH because it is peakless. So here you could see your long-acting insulin profiles such as glargine, detamere, and insulin degludec, which is an ultra-long-acting insulin with a half-life of about 42 hours and can actually be dosed 2 to 3 times weekly. It doesn't necessarily need to be dosed every day. It's still fairly new on the market, but I think we probably will start to see it being dispensed more. But you could see that these are peakless, and they really do provide very steady and predictable absorption to provide that background basal coverage throughout the day.